Sir, are my slides visible, sir?
Yeah.
Good evening, everyone. I would like to welcome you all for today's 4E webinar, which is organized by Endocrine Society of Bengal. The topic for today's webinar is neonatal hypoglycemia. We have two speakers. We have one speaker and one chairperson for today's webinar. First, I would like to introduce the chairperson for today's talk, Dr. Jaydeep Chaudhary, sir. Sir is a professor and in the Department of Pediatrics at Institute of Child Health, Kolkata. Sir is a chairperson, previously a chairperson at IAP chapter of 2020 and also vice president at Central IAP of 2009. Sir has special areas of interest in infectious disease and vaccinology. Sir, welcome. Next, I would like to introduce the speaker for the day, Dr. Arindam Ray, sir. Sir is an assistant professor in the Department of General Medicine at College of Medicine in Sagore Dutta Hospital, Kolkata. Sir is also visiting consultant endocrinology at Zenith Hospital, Kolkata. Sir has many publications till date in peer-reviewed index national and international journal. And also, sir is a co-author of various chapters on endocrinology in several textbooks. So, sir, I would like to hand over to you to continue the further talk, sir. Arindam, sir.
May I request Jaydeep sir to please introduce
Jaydeep, please introduce the topic.
Thank you, Endocrinology Society of Bengal, and especially Dr. Nilanjan Sengupta for inviting me to this forum. Actually, neonatal hypoglycemia is a very common presentation that we encounter in neonates in our day-to-day practice. It's a multifactorial, actually. I mean, it's a multifactorial. I hope that Dr. Arindam Ray will deliberate on the different aspects of neonatal hypoglycemia. The main concern about neonatal hypoglycemia that we are all scared about is the effect of hypoglycemia on the developing brain. That's our main concern. So the normoglycemic status that has to be established as early as possible in a neonate so that we do not have the sequelae of hypoglycemia. I think we can discuss some aspects of this after the presentation by Dr. Ray. So I will request Dr. Ray to please deliberate on this very important topic in neonates, and then we can have a discussion.
Thank you, sir. Thank you. And also thanks to Endocrine Society of Bengal. Thanks, Deep, for your kind introduction, and thanks, Nilanjan sir, for giving me opportunity again and again for giving the talk on different topics. So today, as Sarah has already introduced, it's a very important talk that the neonatal hypoglycemia. So I think my slides visible. Deep, please just
Yes, sir. Your slides are visible, sir.
confirm.
Yes, sir.
Yeah. Okay. Thank you. Thank you. So the neonatal hypoglycemia, neonates the age of the baby when it's less than 4 weeks of age. So when it's out of the mother's tomb, actually the baby faces a lot of the physiologic challenges, and out of which this glucose metabolism is a very important issue. And it's very common that the fetus actually highly dependent on the mother's blood sugar, but when it comes out of the mother's tomb, it actually depends on the outside the blood the feeding, but initial few hours of life actually devoid of this the glucose, and that is the culprit issue which ultimately lands up the baby in this hypoglycemic episodes. But the majority of the times we actually face the issue that the definition of this hypoglycemia in this the neonates are actually very difficult, because different the bodies are there, they actually define the hypoglycemia at their own voice. So the Endocrine Society of Pediatrics, the American Association of Pediatrics, they define the different values of this hypoglycemia. And the most important thing is the normal range of blood glucose is actually variable. It depends on the different issues like the gestation of the baby, the mother, the hour of the baby after the birth, and it actually the various investigators that have also empirically recommend different blood glucose levels that should be maintained in the neonatal period to prevent the injury. That is already said that developing brain is the most, the vulnerable organ for this hypoglycemia. So as I've already mentioned, the body weight, the gestational age, the body stores of the glucose, the feeding status of the baby, availability of the energy sources, usually or the presence or absence of any kind of disease underlying. So these are all the factors that actually determine how the baby will handle this blood glucose, whether he will or she will ultimately land up with hypoglycemia. So there is definitely a consensus there to evolve an operational threshold of this blood glucose level to define the hypoglycemia, and there is no concrete evidence to show the causation of the adverse, the long-term outcomes by particular levels, duration of hypoglycemia that is yet to be determined. But in majority, the WHO defines the hypoglycemia when the blood glucose level is 45 milligram per dl. So the operational threshold by the different bodies suggests that a blood glucose level of 40 milligram per dl can be taken and it's well accepted. But definitely, it can be defined that any concentration of plasma or the whole blood glucose at which the clinician should consider that must take some intervention. Our textbook of endocrine textbook of Williams, they have suggested, that for less than 48 hours of age, a blood glucose level of 40 milligram per dl, and more than 48 hours of age, a blood glucose level of 50 milligram per dl can be taken as the cutoff for hypoglycemia. Whereas the critical sample should be taken when the blood glucose level is less than 55 milligram per dl. That is also important for the adult values almost, and target blood glucose should be 70 milligram per dl or above. So this is the incidence of hypoglycemia. Yeah, hello. Hello.
సార్ మీ డాక్టర్ తో మాట్లాడాను అది ఏం లేదు సార్ హైదరాబాద్ లో
Hello. Is there an interruption, please, Deep?
I think there somebody has entered. Deep, actually, what you do, you just mute all others who is not speaking. As host, you do that. Okay.
Thank you, sir. Thank you. So this slide actually shows the incidences of hypoglycemia, overall hypoglycemia 1 to 5 out of 1,000 live births. Whereas at-risk infants, they actually, I will define in the next few slides that who are the actually at-risk infants, and that counts almost to the tune of 30%. Whereas the preterm babies kind of 15%, small for gestational age 15%, large babies account 8%, and the babies of infants of diabetic mother count of about 20% who presents with this hypoglycemia. So this is the normal the physiologic change that happens when any kind of the living organism actually face this hypoglycemia. So what are the sequences when the first there is cutoff of this the blood glucose level goes below the 70 milligram per dl, there is the reduction of the insulin secretion, and after that there is increase in the glucagon and epinephrine release that happens with the blood glucose level of almost 68 milligram per dl, and then cortisol and growth hormone comes into action when the blood glucose reaches to 60 milligram per dl. The subtle EEG changes that the brain actually starts action when it comes to 55 milligram per dl, and ultimately obvious impaired cognitive function happens when it's less than 50 or 45 milligram per dl, and the neonatal the neuronal death and the brain damage happens if it goes to beyond the less than 18 milligram per dl. So these are the different hormonal regulations that very important that we have to remember when we actually see a phase of hypoglycemia. So this is the insulin that actually important for hepatic glycogenolysis. It inhibits hepatic glycogenolysis. It inhibits the hepatic gluconeogenesis. It inhibits the adipose tissue lipolysis at the same time, the hepatic ketogenesis. The glucagon in the other way actually it only stimulates the hepatic glycogenolysis and hepatic the ketogenesis. That is actually it acts on the hepatic glucose metabolism, whereas the adipose tissue is the minimum action. And the epinephrine that all actually stimulates all the four, as I've already mentioned, and the growth hormone that actually that stimulates the hepatic gluconeogenesis and adipose tissue lipolysis, whereas cortisol has its action only on the hepatic gluconeogenesis. So these are the counter regulatory hormones that actually start in the action, as I've already mentioned, different blood glucose level when any baby or the patient actually suffers from hypoglycemia with decreasing blood glucose level. So this is the glucose homeostasis in the fetal physiology. So the glucose concentration is about to 70% of the maternal value, and actually glucose is the source of the glucose in the fetus is absolutely on a on the basis of the mother's blood glucose level, completely dependent on the mother blood glucose level, because there are some enzymes of the glycogenolysis and the gluconeogenesis that are actually not acting properly in the fetal life, like that of the phosphoenol pyruvate kinase, or pyruvate kinase, or glucose 6-phosphatase, or fructose 1,6 biphosphate. So these are the enzymes actually may be absent or very low level. They're working in the fetal life. So when in the last trimester of the baby's growth, actually this hormone starts actioning, and there is a very little, the deposition of the liver fat is there. So when a baby actually comes out of the mother's womb, when the blood glucose level suddenly starts dropping, the very minimal liver fat is the this glycogen stored is there, and that comes into action and actually increasing the blood glucose level, and that actually stabilizes up to 4 to 6 hours after the delivery of the baby. And when this actually comes into action, the enzymes, the neoglucogenesis, actually there is a process that actually comes into action and starts to rise the blood glucose level. In the same time, the free fatty acid and the ketone bodies. So glucagon actually starts production by 15 weeks of gestation, and whereas the insulin start production by 12 weeks of gestation, and increase in third trimester, and fetal glycogen deposits begin in the 9th week and increase by the third trimester. So this is the gluconeogenesis that complements the glycogenolysis in the neonate, and at the same time the falling blood glucose causes a surge in the fetal cortisol, surge in the glucagon, and decrease in the plasma insulin. What I've already mentioned is the lipolysis, the free fatty acid and ketones, sparing the glucose utilization, particularly for the major organs like the heart, liver, muscle, brain, producing NADH, and for the gluconeogenesis. And the brain glucose uptake is insulin independent, and at the same time the metabolism is supported by the part of the oxidation of the ketone and the lactate. So why the hypoglycemia is a major problem in the neonate? Because the glucose is a primary fuel for the brain, and the brain needs a steady supply of glucose to function normally. Glucose in the fetus only source is a carbohydrate, and compared to adults, infants have a higher brain to body weight ratio, resulting in higher glucose demand in relation to glucose production capacity. And cerebral glucose utilization, it accounts for almost 90% of the neonate's glucose consumption. So what are the different changes that happens in the birth? That the fetal glucose, plasma glucose, is almost 60 to 80% of the maternal glucose. The fetal stores of glucose in the form of glycogen, the liver, the heart, lungs, skeletal muscle. And most of the glycogen is made and stored in the last month of the third trimester. This I've already mentioned. So when the infant is born, the cord is cut, so the major supply of the glucose cut down, and the transition from the fetus to newborn creates a significant energy drain to the newborn. And newborn is required to meet the increased metabolic demands while changing the energy source from the placenta supplied source to the external food source. That's why, as early possible, the feeding is assured. So if you think about the etiology, the decreased substrate availability in the form of the IUGR and the glycogen storage disease, the inborn errors of metabolism like the fructose intolerance, the prematurity, prolonged fasting without the IV glucose. So these are the causes, the decreased substrate availability, whereas a hyperinsulinism is a cause of hypoglycemia, like infants of diabetic mother, islet cell hyperplasia, erythroblastosis fetalis, exchange transfusion. Beckwith-Wedman syndrome, that's either the maternal drugs like terbutaline, propranolol, chlorpromazine, or the benzodiazepides. These are important to cause the fetal hypoglycemia, the neonatal hypoglycemia. And at the same time, the abrupt cessation of the IV glucose is another cause. Whereas increased glucose utilization in the form of hypothermia, increased walk of breathing, sepsis is a very important cause of neonatal hypoglycemia. And truly speaking, in every neonatal intensive care unit, the babies who are actually supposed to have this hypoglycemia, majority are actually suffering from sepsis, neonatal sepsis, the perinatal asphyxia. Endocrine abnormalities in true sense are not so common, but definitely we have to think about the panhypopituitarism, congenital hypothyroidism, or the adrenal insufficiency, maybe in the form of congenital adrenal hyperplasia, when we face the patient, the baby actually suffering from persistent or the recurrent hypoglycemia. At the same time, the polycythemia, congenital heart disease, and CNS abnormalities may be the other causes of the hypoglycemia. So these are the high risk group, as I've already mentioned. The low birth weight infants of less than 2 kg, The preterm infants, the small for gestational age, which is defined as a birth weight of less than 10th percentile. The infant of the diabetic mother, large for gestational age with a birth weight more than 90th percentile. The infant of the Rh hemolytic disease. The infant who are actually born to the mothers receiving therapy of the terbutaline, propranolol, labetalol, oral hypoglycemic agent, infant with the morphological IOGA, any sick neonate, such as those with the perinatal asphyxia, polycythemia, sepsis, shock, or the infants of total parenteral nutrition. So this is the the effects on the fetus of the infant of diabetic mother, because the diabetic mother has a lot of glucose in the body, and that actually transmits in the baby, but insulin actually does not cross the placenta. So whatever be the insulin that is secreted in the baby due to the hypoglycemic status, that actually also there in the just after the birth. So when the glucose actually supplies cut down, this hyperinsulinemic state may cause a hypoglycemia in this category of the babies. So excess formation of these oxygen radicals that actually damage the mitochondria, and this increase in the oxidative stress that results this is the vascularization of the developing tissues, and that is the cause in majority of the times of different the congenital anomalies that actually present in the babies of this infant of these diabetic mothers. So this is the transient hypoglycemia. There is the insufficient calorie intake or the delayed onset of feeding, large for gestational age, small for gestational age, IOG infant of this diabetic mother, or the GDM patients, or the post-mature, the premature infant, infection, sepsis, shock, respiratory stress, perinatal stress, asphyxia, hypoxic ischemic encephalopathy, hypothermia or hyperthermia, polycythemia, erythrobasculosis fetalis. So these are the causes of transient hypoglycemia, whereas the persistent hypoglycemia, which is defined as the hypoglycemia that lasting for more than 7 days, or infant who require the higher amount of glucose, the transfusion rate usually more than 8 milligram per kg per minute, whereas some bodies are there who define it's more than 10 to 12 milligram per kg per minute, to maintain the normal glucose level of more than 70 milligram per dl for over a week. Usually the causes are the endocrine disorders are there, like the growth hormone deficiency, congenital hypopituitarism, congenital hypothyroidism, whereas the hyperinsulinism is another cause. It's the congenital, like the potassium ATP is channel the anomalies, or the B cell adenoma, or any kind of syndrome like Pigman syndrome or Soto syndrome. Inborn errors of metabolism like galactosemia or glycogen storage disease, fatty acid oxidation defect, disorders of amino acid metabolism also are very important in this aspect. So these are the infant at risk, and what's the mechanism behind that? When the preterm baby is there, the presentation is there because of the low substrate, immature, the hormone secretion, the fluid restriction is a feeding difficulty. For IOGI babies, because of the poor temperature control, for the low substrate, again, immature hormone preparation, at the same time, the fluid restriction, the feeding difficulty. For IDM, as I've already mentioned, hyperinsulinism is the cause. For perinatal hypoxia, again, the enzyme dysfunction, exhausted stress response, the feeding difficulty, hyperinsulinism. For septicemia is very important, the exhausted stress response, enzyme dysfunction, fluid restriction, feeding difficulty. And for inborn errors of metabolism, the defects of the enzymes of the glycogenesis, glycogenolysis, and fatty acid oxidation, very important. So this is the time schedule for screening the babies for for hypoglycemia, when we have to check the blood glucose. At risk infants, we have to take it the samples at 2 hours, 6 hours, 12, 24, 40, 72 hours. For sick infants with sepsis, asphyxia, shock during the active phase of illness, and once underlying conditions under control, frequency of the screening can be reduced, but definitely we have to do it every 6 to 8 hours and individualized as needed. For stable low birth weight infants on parenteral nutrition, the initial 72 every 6 to 8 hours, and after 72 hours once a day, we have to check it. So am I audible, Deep? Am I audible?
Yes, you are perfectly audible.
Yes, sir.
Okay. Thank you. So there's a very debate is there that how to measure the blood glucose, because this glucometer reading many a times are false in this subset of patients, particularly the neonates. So the point of care glucometer, which actually use the glucose oxidase or glucose dehydrogenase, that's a Accu-Checker Optium, that one option is there, but definitely we have to keep in mind these issues. The lab analysis, the glucose oxidase, hexokinase, this GDH use fluoride pearl are the most important one, and that is ideal. The blood gas analyzers, that is also very important, but arterial one will be better than the venous one. And continuous glucose monitoring, in the same form of sensors that identifies up to 3 times more episodes of blood glucose. But there is definitely a question will be that the significance of these episodes and long-term morbidity that is not known even today. So this is the point of care reagent strips, which is actually the first generation of the reflectance meters that is affected with the hematocrit acidosis, at the same time the bilirubin. But the newer ones, based on the current generated on the reaction of the blood and enzymes like hexokinase, glucose dehydrogenase is the better one. The range is usually +10 to -15 milligram per day. When it's less than 50 or more than 500, definitely accuracy is a matter. So the non-invasive neonatal glucose monitoring are the newer devices that actually are based on the principle that the small neutral molecules can easily diffuse to the skin, but depends on the skin permeability. The glucose sensor based on the glucose binding protein here, the 4 orders are more sensitive than any available glucose sensors, and method is actually penless, gentle, and idle for the infants. So which one is better? That's a $1 million question. Laboratory versus is the gold standard, where the calorimetric, the glucose oxidase, hexokinase, glucose electrode method, but the blood class analyzer better than the glucometer that is the glucose oxidase method. There's a high false positivity for hypoglycemia. So these are the clinical signs of hypoglycemia. Most of the patients may be asymptomatic, whereas the symptomatic, a smaller proportion of the infants with hypoglycemia can be presents with the variable symptoms, may include the stupor, jitteriness, tremor, apathy. Evidence of cyanosis can be there. Some definitely the infants can present with the convulsion, intermittent apneic spell with tachypnea, the weak and high pitched cry, limpness, lethargy, difficulty in feeding, and eye rolling. Evidence of sweating, sudden pallor, hypothermia, cardiac arrest have also been reported in some of the units. Now, how to evaluate? Definitely the history is very important. History of the mother, history of the family, at the same time when the first notice the hypoglycemia, what is the presentation? And the pre-eclampsia of the mother, receiving any IV glucose during the delivery, or the oral terbutaline, other drugs, labetalol, or the oral hypoglycemic agents. If the infant at risk for hypoglycemia, prematurity, hypoxia, asphyxia, hypothermia, illness, whether the patient, the infant has a respiratory disease or evidence of sepsis, that definitely is very important. And how much the glucose patient is actually, the neonate is actually receiving, that's also very important. At the same time, what is the rate of glucose transfusion, whether it's the transient hypoglycemia or it's a permanent or recurrent hypoglycemia. Is there any symptoms of hypoglycemia? Poor feeding, lethargy, apnea, jitteriness, seizure, history of consanguinity is very important, because congenital adrenal hyperplasia, that definitely we have to take it in account. The examination, irritability, lethargy, tachypnea, cyanosis, eye rolling, weak or high pitched cry, exaggerated more reflex, these are very important. Now, definitely we have to, as endocrinologist, when being referred for recurrent or persistent hypoglycemia, we have to think of different endocrine causes, where the hypopituitarism, the midline defect, the micropenis for the pan hypopituitarism particularly is very important. We have to think whether it's a growth hormone, particular isolated growth hormone, or thyroid deficiency, or it's a combined, the hormone deficiency. So in this case, we have to, the birth length is also very important. The history of, the congenital, the jaundice, the jaundice, very deep jaundice at birth, that we have to also take in account. At the same time, for congenital adrenal hyperplasia, the ambiguous genitalia, for the maple syrup urine disease, the smell of the urine is very important. At the same time, for LGA, SGA, the anthropometry is also important. The cataract gives some clue for the galactosemic or intrauterine infection. At the same time, the signs of sepsis and shock, and for the infant of diabetic mother, for macrosemic babies, the large, puffy, plump, plethoric congenital malformations like the GIT malformation, renal malformations, cardiovascular malformations, and CNS anomalies that we have to check. So if you think about the investigation, the transient hypoglycemia, the serum blood glucose level, the CBC to rule out any kind of sepsis, polycythemia, electrolytes are very important. For persistent hypoglycemia, we have to determine what is the cause of hypoglycemia. In that case, the critical sample is very important to establish the hyperinsulinemia. So in that case, the insulin, proinsulin, and C-peptide at the same time the blood glucose that we have to draw, and when the critical the blood sugar level drop is there. At the same time, the serum ketone, the lactate, ammonia, we have to draw cortisol, ACTH, growth hormone level, and thyroid function. We have to check when the other causes are not found. At the same time, the urine ketone and reducing substances, amino acid, organic acid, which when we are thinking of the fatty acid oxidation or the amino acid metabolism disorders. So this is in nutshell is maybe a very busy slide, but definitely when the hypoglycemia presence, maternal infant history examination, we have to check first of all whether the patient have the acidosis or whether no acidosis are there. When the acidosis is present, high lactate or the ketosis. So if the patient has high lactate, then short fasting period is there, and patients may land up with the glycogen storage disease, whereas the defect in hepatic gluconeogenesis or the normal ethanol ingestion may be one of the reason. For ketosis is there, then moderate fasting period and defects in glycogenolysis. At the same time, it can be ketotic hypoglycemia, it can be growth hormone or cortisol deficiency. When there is no acidosis present, then we have to check whether the ketosis of the ketone bodies of free fatty acid present. Then if there is not present, then the infant of the diabetic mother, the insulin therapy, the oral hypoglycemic agents, ISGA or the bath hypoxia, neonatal hypopituitarism, infants of the diabetic mother, congenital hyperinsulinism are maybe the causes. When the high free fatty acid present without ketones, then we have to do a prolonged fasting period and patients land up with hypoglycemia. Then definitely the genetic defects of the fatty acid oxidation or the ketogenesis that we have to take it in mind. So this is another the flow chart that shows we can approach it clinically when the hypoglycemia, when hepatomegaly present, or when there is no hepatomegaly present. So if the hepatomegaly is absent, so in that case, the glucose, insulin, cortisol, growth hormone, lactate, and the beta hydroxybutyrate we can measure. When the high insulin level is present, it can present with the hyperinsulinemia. When the low beta hydroxybutyrate, then the defects of fatty acid oxidation, or it can be the hyperinsulinemia. When the hormone deficiency is suspected, like growth hormone, cortisol, definitely we have to treat it accordingly. But if the hepatomegaly present, if the lactate is normal, then defects in glycogen metabolism. If the lactate is high, it can be defect in gluconeogenesis, or it can be normal or ketotic hypoglycemia. So we can follow either one. So this is the flow chart for the hyperinsulinemic hypoglycemia. When the ketones, free fatty acid, branch chain fatty acids are suppressed, so then definitely we have to check the C-peptide level. So if the C-peptide level is elevated, then we have to think of sulfonylurea or the meglitinide. If it's absent, then the insulinoma versus islet cell dysplasia, we have to think of. If the sulfonylurea meglitinide present, then definitely we have to think of for this oral AHA, oral hypoglycemic induced hyperinsulinism. When the C-peptide level is suppressed, then we have to check for the insulin antibodies. If it's present, then exogenous insulin administration versus the autoimmune hypoglycemia, we have to think. When it's absent, then consider about the insulinomimetic auto antibodies. So this is the critical sample values that when the blood glucose level goes beyond that, we have to check it whether the insulin, proinsulin, and C-peptide level. As you can see that the indicative of hyperinsulinism, when the insulin level goes more than 2.5 micro international per ml, where the proinsulin level of more than 2 nanogram per ml, and C-peptide level of more than 1 nanogram per ml in the critical sample that goes in favor of hyperinsulinism. And the typical for insulinoma at the same time, the insulin levels usually 3 to 42, the micro international per ml, whereas that of the proinsulin of usually 0.1 to very high value of 9 nanogram per ml, and C-peptide usually of less than 2, 1 to 9 milligram per, the nanogram per ml. Though these are actually the data collected from different studies of the adult patients, but out of all the studies, actually majority of the studies are actually carrying 3% of the patients of 12 to 20 years of the age. So this is the management of the hypoglycemia in very nutshell. I will just give you when the blood glucose level drops to less than 40. 5 milligram per dl, whether we have to check whether the patient is actually symptomatic or asymptomatic. So if the for asymptomatic individuals, if it's less than 25 milligram per DL, we have to follow the symptomatic hypoglycemia I will show in the next slide. Whereas if it's 25 to 45 milligram per DL, we have to try for the oral feeding. We have to check the blood sugar every 30 to 60 minutes. If it goes above 45 milligram per DL, we have to check it every 6 to 8 hourly and stop after 48 hours. If it's again less than 45 milligram per DL, then we have to follow the symptomatic hypoglycemia protocol. So what is the management for symptomatic hypoglycemia? We have to give the bolus of 2 ml per kg, 10% dextrose. Then IV glucose infusion at the rate of 4 to 6 milligram per kg per minute, and monitor every 30 to 60 minutes. And we have to check the blood glucose level every 6 hourly. When it goes more than 45 milligram per DL, stable for 24 hours on IV fluid, we have to wean it at 2 milligram per kg per minute every 6 hours, monitor 6 hourly, increase the oral feeding, and stop IV infusion when the rate is actually 4 milligram per kg per minute. But if the blood glucose level is less than 45 milligram per DL, then we have to increase the glucose infusion rate at the rate of 2 milligram per kg per minute up to 12 milligram per kg per minute, and refer to us as per the endocrinology concern for persistent the recurrent hypoglycemia protocol. So this is the treatment for the resistant hypoglycemia. As I've already mentioned, when the glucose infusion rate is usually more than 8 to 10 milligram per kg per so if the hypoglycemia persists despite the high glucose delivery rate, then the drugs choice are usually the hydrocortisone, 5 milligram per kg per day IV or per oral, 2 divided doses. The diazoxide can be given at the rate, the dose of 5 to 15 or maybe 10 to 25 milligram per kg per day in 3 divided doses, or octreotide, the somatostatin in a good dose of 2 to 10 microgram per kg per day can be increased up to 15 to 20 microgram per kg per day, subcutaneous 2 to 3 times a day. And glucagon can be also given 100 microgram per day to up to 300 microgram per day. So this is the specific management, for congenital hypopituitarism, the metabolic defects of the GSD galactosemia. We have to check the outcomes of hypoglycemia, usually determined by the factors like the duration of hypoglycemia, the degree of hypoglycemia, the rate of cerebral blood flow, and the cerebral utilization of the glucose, and also the comorbidities. It is unlikely that the brief self-limiting episodes of any neurological significance, but adverse neurological signs has been associated with long-term outcome. And there must be some special attention should be paid to neurodevelopmental outcome, overall IQ, reading ability, arithmetic proficiency, and motor performance. So how to prevent, increase awareness of the condition that predispose this hypoglycemia and infant to hypoglycemia, definitely at risk persons. The protocol for the checking the blood glucose is very important. We have don't be casual with this. Definitely we have to check it as frequently as possible, as I've already mentioned. Early screening of the at-risk infants, early and frequent feedings, and maintenance of the temperature, that's also very important. So thank you. I think this is the last slide. So may I request the chairperson sir to proceed for the Q&A session, please.
Thank you, Dr. Ray, for this extensive presentation. Few points that you have touched are very significant. One is the consensus about neonatal hypoglycemia. Well, absolutely. It's either 40 or 45 as per the different authorities, but let's make it 45 for convenience sake. That's the figure that's usually followed by most of the societies. And also you have mentioned that's another important aspect is that below 48 hours and above 48 hours. Below 48 hours if it's below 40, and above 48 hours below 50, that's we take. But what's a very critical point that is not addressed by most of the societies and expert also about the duration of hypoglycemia. Well, the duration of hypoglycemia that may really cause the brain damage, that's not very well defined. I think you have also come across this dilemma. That's why monitoring is very important, because the presenting symptoms of neonatal hypoglycemia is by and large non-specific. Lethargy is a very relative term, and lethargy may be due to various other causes. Only when it progresses and the duration is longer, then we might get the jitteriness, Again, if a jittery neonate comes, we have to think of hypocalcemia also, really hypomagnesemia. High-pitched cry is also a very soft sign in the sense that it may be a feature of both asphyxia and hypoxic ischemic encephalopathy also. And cyanosis is another feature which is common to hypoglycemia, sepsis, a congenital heart disease. So by and large, we have to be very vigilant. That's the reason why we have to screen the babies who are at risk. We all know that infants born to diabetic mother is definitely, as you have discussed, definitely is at risk due to the inherent hyperinsulinemic state. Another common situations are the preterm babies, the small for gestational age, and the birth asphyxiated neonates. Other than that, if a baby is born normally or a baby is delivered by cesarean section, thriving well, not preterm, birth weight within normal range, then there is no need to routinely monitor blood sugar level, but initiate breastfeeding as early as possible. But if a baby falls beyond this range, like preterm, small for gestation, birth asphyxia, infants of diabetic mother, then definitely early monitoring of blood glucose is very important, because here the duration of hypoglycemia is also critical. Regarding the frequency of blood sugar monitoring, you have told that it's 2 hours. Yes, definitely. But if it's an asymptomatic baby, then after giving the bolus of 2 ml per kg of 10% dextrose, we must recheck the blood glucose at say 20 to 30 minutes. And then if still it's low, we can give a second bolus, and then if required, give a maintenance of 6 to 8 milligram per kg. Fortunately, the need for pharmacological intervention is less in neonates. And most commonly, if it's a symptomatic hypoglycemia, usually we can control it by injection hydrocortisone alone. Diazoxide is rarely used. But overall, the neonatal hypoglycemia is such a critical area, critical aspect. It's a fine balance, because you have extensively explained the effect on the brain and the utilization of glucose in the brain, and the developing brain is so susceptible to hypoglycemia. Even if it's a sepsis, usually sepsis is not that early. It's usually maybe after 48 hours that usually, I mean, we might encounter sepsis. There also monitoring blood glucose level is very critical, because sometimes we are over focused on managing sepsis per se, forgetting the metabolic part, like blood glucose monitoring mainly, then other electrolytes and also the other factors also do come. Fortunately, we see very few cases of really congenital malformation presenting with hypoglycemia or other difficult endocrinological cases that that it's rare. What we get very frequently, this one aspect is sometimes ignored by the pediatricians and the neonatologists also, is the poor feeding leading to hypoglycemia. Because there is a trend to discharge the baby early, maybe within or after 24 hours of birth. If it's a normal delivery, baby is discharged, the mother takes the baby home. There is an anxiety factor, and that really hinders the breast milk production, and there is inadequate breast milk production, not proper motivation of the mother, inadequate feeding, baby becomes lethargic, poor suck, and further poor flow of breast milk, precipitating hypoglycemia. And when these babies are brought, they are probably in a critical hypoglycemic phase and maybe having seizures or severe brain damage. So this aspect is sometimes overlooked because counseling about early breastfeeding, proper breastfeeding, technique of breastfeeding, this is a very simple situation which can be easily tackled, but sometimes overlooked. We are also part of the system that motivation and initiation of early breastfeeding, proper breastfeeding, because many a times children do come back just due to poor feeding because mothers are not aware. They are very anxious, and that also hinders breast milk production. So any other question, I think we can discuss and go forward.
So we have one question, sir.
Yeah.
Can we use Lipro for neonatal hypoglycemia? The product insert recommend not to use it below 4 years of age.
So I think it's not, any studies are there that can prove that it will say the results will be reproducible in neonates. So definitely before using it, we have to do some studies for proving it to be reproducible. But as the the material says that after 4 years of age, it can be used. So it's I think will not be we can use it in the baby. Sir, what's your suggestion?
About this, I am not aware. Sorry.
Yeah, but definitely, I think the laboratory values are the most important one. But you can check it with the glucometer. But there is definitely the hypoglycemia. There is more of false positive values. The incidence are there with the hypoglycemia, but the studies are actually going. So this is not the correct time to say whether we can use it in the neonate particularly.
No, may I comment? Regarding this thing? I think this is a very sensitive investigation, any CGM or AGP continuous glucose monitoring. So we do not, since they have kept it 4 years of age, that means they haven't studied it. So in the absence of normative values with this instrument, at least if not anything else, there would be problems of fixing, maintaining it. Those things would be there in a neonate. I'm not talking of a small child, it's a neonate only. So that would be a problem. And the second thing is that in the absence of normative data in that age group, it will be difficult to interpret. If you can generate some results, it will be difficult to interpret.
Yes, sir. So any question, further question, Deep?
Sir, no, nothing. Sir, they have not put no one question in the chat box, sir.
I think your deliberation was extensive and it covered all the points. I mean, it's a great learning, and you really covered everything, right from the neonatal presentation up to the management. And even when we studied and we also teach, I think we can't add any other points than what you have deliberated. And in all our textbooks also covers this only. So it was a very nice presentation. Thank you.
Thank you, sir. Thank you. So I think the most common cause are because of this poor feeding, delayed feeding, or the sepsis related issues, and the infant of diabetic mother. So these are the most common causes of any hypoglycemia. Because we also in our postdoctoral days we have found very little number of cases of this panhypopituitarism or isolated GH deficiency or congenital adrenal hyperplasia. They are presenting with this kind of situations. So we have to take it in mind definitely, but the rare causes actually comes very rarely. So the common causes we have to think first and we have to treat it.
Right. Sometimes we do encounter Beckwith-Weidman syndrome, but congenital adrenal hyperplasia presenting as neonatal hypoglycemia is relatively rare. As you told that, see, for infant of diabetic mother or a preterm or SGA, we are more or less prepared. We should be prepared because usually the pregnancies are monitored nowadays very well. So infants of diabetic mother and also preterm, it's usually a planned delivery sort of. So we are usually prepared. Sepsis, sepsis doesn't present right at birth, but of course, There may be early sepsis within 7 days or delayed sepsis beyond 7 days. And even in a septic child, we definitely, I mean, it's part of the protocol to check the blood glucose level and monitor for that. Sometimes what comes as a unexpectedly are that number one is poor feeding, number two is feeding diluted formula. So these are some things, I mean, say a baby who has been brought to the emergency with lethargy, and while we check, we find that it's a hypoglycemia. Often we just tend to overlook that it could be a faulty feeding. So that's one of the factors that I wanted to stress, especially for, say, the students who will be attending the emergency babies and all that. So that we also tell, because that we should not go into investigating further on such cases, but take a history that what type of feed you offered the baby. So that's a very common practice, because even I am sorry to say, the some of the so-called sisters and the attendants, they often prescribe, and even the family members, you take some infant milk formula and offer a diluted formula to the baby. So it's a very, very diluted formula they give, and the baby becomes lethargic, hypoglycemic, passing frequent urine, and the babies become dehydrated and hypoglycemic. So it's a horrible situation. So this is probably, as in a pediatric hospital, a very commonly encountered scenario, that hypoglycemic baby is coming like that.
I have a question that, sir, you were working in a hospital which actually deals a lot of patients of, the congenital issues. Now, so what's your experience of this CAR6.1 or, the SUR1 mutation causing hyperinsulinemia? So what are the incidences? I've never seen a patient, or maybe undiagnosed most of the time. So
undiagnosed maybe, but I really, frankly speaking, we haven't encountered. I don't remember in the past quite a few years we haven't encountered.
Because textbook says this is the commonest cause of hyperinsulinemia in causing hypoglycemia.
No, I mean, we haven't encountered.
It's okay. So Deep, is there any further question?
Thank you, Arindam. No, sir, no more questions, sir. So thank you, Arindam, sir, for such an extensive talk. Thank you, Jaydeep, sir, for giving us a valuable time. I would like to thank our audience for giving us time in such difficult situations. And sir, you can conclude the session for today, sir.
Nilanjan Gupta sir is there? Sir, are you there?
Yes, sir is there.
Okay, I'm there, but I have nothing to say. Deep has already concluded the meeting. Once again, thanks to both of you, and thanks to all the participants. It is really mentally challenging, if not physically. It's very mentally challenging to participate, but I also had a very good and extensive revision of what I knew, and I learned many things, which was a good updation. So, and this will be archived and would be put up in our YouTube channel. So those who have missed it can again go through it in better times to have a great understanding, because this is an important practical problem. And this is also a theoretical question in the DM exam. So I think, thank you very much. And okay, I take the privilege of declaring this meeting closed. Thank you.
Thank you.
Thank you, STSF, sir. Good night.